So what about endoscopy errors? Why are we worried about this? Well, we know from our prospective observational studies that errors are common and they occur frequently. And in this study where we looked at 140 procedures, we actually counted 140 errors. Now, 2/3 of these were minor and moderate and endoscopy. When we look back at the anatomy of that, in just over 1,000 endoscopy adverse events, we categorised and encoded these. And actually, interestingly, 600 or so were related to the procedure, but there was a big proportion, that were related to errors that occur outside of the endoscopy room. So this is a real important aspect of us addressing patient safety. And when we look at these in further detail through this Pareto plot, some of the things that you may not think are important, things like surveillance, managing histology, these are the things that were represented in this national database. So the summary of this talk I'm going to put at the front. I'm going to go through 6 brief mistakes that published in the UEG article. So the first one relates to patient selection. Then I'm going to talk about planning and preparation, how to manage intubation, which is a key part that induces anxiety for our patients, how to optimise extubation and avoid mistakes there, thinking about our communication and non-technical skills, particularly when you encounter a complication, and then finally documentation. So the first mistake is doing an endoscopy on a patient that doesn't need it. This is actually quite tricky when we think about the volume of referrals that we all receive for endoscopy. When we think about straight to test pathways, we often don't know what this patient is about and whether they can even undergo an endoscopy. So pre-assessment becomes really crucial in this setting. And we now have more tools such as the Charlton Comorbidity Index and frailty scores that may help us fine-tune which patients might be suitable for surgery and which ones might not. We know we have an aging comorbid patient population with the attendant risks of anticoagulation and thrombotic risk, which are really complex things to manage. And really sometimes an MDT discussion, such as a complex polyp meeting, might be really needed to say, should we scope this patient, not just can we? Counselling and consent is a process, it's not just the yellow form, and it starts well before the endoscopy. And once you've made that decision, then it's really important to think about discussing it with the endoscopist that might be doing the actual procedure, because they may have a different approach. We all know that cancelling an endoscopy is really cumbersome and difficult, and it's so much more difficult to do, but it may be the best thing for that particular patient if you, as the endoscopist, don't think the indication is correct, and maybe presenting an alternative investigation such as appropriate imaging prior to endoscopy. And really all this takes quite a lot of time, but actually thinking about how you might optimise that patient for the best endoscopy, this whole concept of getting it right first time with regards to bowel preparation, anticoagulation, sedation plan, and managing their expectations. And I really like this surgical maxim about a good surgeon knows how to operate, a better one knows when to operate, and the best ones know when not to operate. And this was actually from 1963 by Francis Moore, this transplant surgeon. And you can't read it very clearly in the banner above, but it says, you're lucky if they can operate on you. And I think we can now say, people say, well, they're lucky if they can scope you, because actually patients that aren't being put forward for surgery are being considered for endoscopy. And this leads really nicely into the revised BSG guidelines on consent, which I think I would advise you all to read, because it's really shared decision-making and consent are often phrases that are banded but not actually done very well. So I think consent is really key here in patient selection. The next mistake relates to planning. So skip the team briefing and the checklist because you're running short of time. We often get caught into this trap, but actually, this is a really important aspect of avoiding errors before the patient gets to the room. And during the COVID pandemic, we published this adaptive changing processes in endoscopy. Is that you have a whole team huddle at the beginning of the day with your nursing team, your decontamination staff, to see what issues around the unit are. And then you have a team huddle with the people that you're doing the endoscopy list with, so that you can really drill down on the mechanics of the cases, prep the nurses on the kit that you might need, think about the order of your list to avoid mistakes translating into the room. And to close the loop, there's also a debriefing section that you can employ. And this obviously leads very nicely into the checklist, which is another safety tool at the last moment before the scope is inserted. And I think this is now sort of widely used, but actually this is a relatively new intervention in our safety approach to endoscopy, but the briefing helps the safety checklist so that you get to the point where the patients come in appropriately prepared. So think about special situations, make sure your kit is present and functioning, not just planning for the patient, but planning for the endoscopy team as well, and ergonomics is key here. Thinking about that particular patient's experience on that day, is this their post-colonoscopy cancer surveillance procedure and they have huge anxiety, might impact your sedation plan. And I think this is a really key point, being receptive to new, critical or changing information from your team. So if something's changed, but you've got a set plan, be willing to adapt. And setting your limits, think about your plan B and communicate that with your nursing team so they can hold you to account. I don't have time to go into this in detail, but ergonomics is a key part of planning and setting up your room correctly to ensure that you not only limit the difficulties that you might experience as an endoscopist over time, but also so that you can actually do your procedure in the best fashion is really important. And I think when we think about patient safety, we always think about endoscopy for patients, but actually we have to think about the endoscopists too. So planning your room, planning your team, planning your environment is key. Maybe not so for a quick diagnostic endoscopy, but when you're thinking about more advanced procedures such as ESD or POEM, these things will come into play. So the third mistake relates to intubation. Just get the scope down. You're running late, just get going with the procedure. And we know that this is the most difficult part of the procedure for the patient, where their anxiety is at peak. So I think with regards to upper GI endoscopy, minimising the gag reflex and managing that first aspect is key to buying trust. And with regards to colonoscopy, doing an intimate digital rectal examination is often the most tricky part of that experience from the patient's perspective. And we know that lots of our patient-reported outcomes are clinician-orientated, whereas the team at Newcastle have talked about patient-derived outcomes. And we know that endoscopy is traumatic, even though we like to do endoscopy to patients. Patients' experience of it is challenging. Your intubation is really important to get right, because it's the bit where you develop a rapport, you can build trust, you can set ground rules, and also it's a patient contract. So they know what to expect and you know what they've agreed to. So for example, if a patient wants the procedure to stop at any point, you have an understanding of how you're going to do that. And really, I think this comes onto patient comfort and acceptability of the procedure and tolerance, and this leads nicely into the updated sedation guidelines. So how can you improve the experience of patients with intubation? Well, I think a key here is, with regards to upper GI endoscopy, starting with the right communication. So explaining the throat spray, if you're going to use that, is probably a really important aspect. And I'll direct you to Boo Hay, who has a wonderful video explaining how well to do throat spray to minimise gag reflex, and thinking about the glossopharyngeal nerve anatomy and the lingual portion first rather than the pharyngeal portion. Think about when you're going to place the mouth guard, how you're going to communicate to the patient, and really importantly, giving the conscious sedation time to work. We know that we don't give the 3 minutes that's required for midazolam quite often when we're rushing, but actually if you do spend time doing this, you'll reap gains further down the procedure. Avoid washing in the pharynx, it just causes discomfort. Use suction and try to intubate under direct vision. So what about colonoscopy? Again, communication and language is key. So I think ensuring privacy and dignity is a key aspect here. And things like if you're talking to the patient, I have the room lights down, the door locked, and I say, I'm just going to separate these shorts and examine you with a bit of cold jelly, rather than I'm just ripping these shorts apart. The environment, I think, being set up for that. Gastroenterologists are not very good at detecting anorectal pathology, and documenting this in your report is a key aspect, particularly, for example, perianal Crohn's disease, but also other pathology. And thinking about your rectal examination before you insert the scope. It just gives you an idea of the direction of the anal canal and how you're going to actually insert your scope. And some people will do a digital rectal exam and actually insert the scope over their examining finger, a bit like a Seldinger technique, to avoid the in-out discomfort of passage through the anorectum. Retroflexion up front is a good way of detecting important pathology at the beginning of the procedure and potentially minimising discomfort when the sedation may be maximal, and having a plan for how you're going to do this intubation. Are you going to use water insertion? Might CO2 be best? What is the anatomy here and what's the bowel prep like might feature into those decisions. And really, for comfortable colonoscopy, the key is the loop, prevention, recognition and resolution, and planning a new therapy that you might have planned. So the fourth mistake relates to extubation. So we all love these images, beautiful cecal landmarks. You can relax with the cecum now, we're over, we're done, we're home. This is incorrect. This is where the procedure actually starts. But we have to be mindful of the fact that actually this is the point where cognitive attention may be diminished, and the endoscopist and the team and the patient might be quite fatigued and fed up, particularly if you've had a difficult intubation. So in this scenario, I think we've got important to think about marginal gain. So you can see Professor Thomas Gibson's video on your screen here, and she's using all the adjuncts. So we think about making sure we optimise use with Buscopan, endocuff, wash, digital enhancement, whether that be chromoendoscopy or artificial intelligence. And really important to think about using all of the time you spend in withdrawal to actually looking and to detect pathology. There's this concept of getting caught up in the mechanics of, for example, retroflexion, but not picking up the actual pathology. And a tolerance for poor bowel prep will lead on to suboptimal bowel preparation, and we know that links to PCCRC. And you can see here on the video that we now get to the cecum, and you see the views aren't very good, but you can see very well that position change, particularly on the back, but also the right lateral, really just helps optimise your view here. So think about what you do in the time for withdrawal to make sure you give that patient the best chance to detect the pathology you're looking for. So the fifth mistake relates to sort of dismissing or minimising errors. This is a quote some time back from a trainee who thought, oh, that's the biggest polyp I've ever seen. And, you know, lo and behold, complications occur, and this is quite a serious complication of an obvious perforation. But this scenario will also apply to lower level of errors as well. And really, the way to sort of think about this, how you manage your communication and error. In an era where we're all going to be doing potentially more advanced endoscopy with more therapeutic procedures, we are going to come across more complications, but we're not necessarily well versed in how to manage that. We don't have mental rehearsal, for example, as to how are you going to deal with that perforation in the room? What is the language you're going to use? How are you going to ask for help? And really this relates to these non-technical skills that support our technical skills. Communication, leadership, situational awareness, and judgment and decision-making, all of which come under extra strain during a complication. And often we think about the hierarchy and delegation and how we're going to change the leadership if the dynamics of the room change. Recognising and calling for help early is really hard to do, but it's important. I always like to know if I've got a tricky case who's in the room next door and where my surgical colleagues are. But we know that when you have a stressful situation, a complication, most people go into tunnel vision with cognitive overload, so they may not be able to make those decisions, at which point the nursing team or others in the room, the trainees, may have to step up and speak out and help. Silence during a complication can be tricky. We often all know when the tone of the room changes, something serious has gone on, and the patient is not averse to that either. Many patients may be unsedated or consciously sedated, so you have to think about how you're going to manage the communication to them. You know, yes, there is a bit of a bleeding. I'm going to concentrate on this now, but my nursing colleague's going to talk to you about it. And I think individualising patient communication in that scenario is really important, but you may need to delegate that out. And an increasing area of interest is, I think, this managed support process, almost this pastoral aspect of when you have a complication, how do you support the endoscopist and the nursing team after the event? We're obviously very focused on making sure that the patient is safe, and of course that's the first priority. But actually this is quite traumatising for the endoscopist and the team, and we have to think about how we ensure they're safe to do further procedures, separate to the governance of the serious incident review process that we're all familiar with. So the last mistake I'm going to talk about relates to documentation. So after all of that time you spent doing a briefing, doing a challenging intubation, detecting a large polyp, and then dealing with the complication, you're absolutely exhausted, but then you've got to deal with the electronic patient record. Now, we all know that there's good evidence for photo documentation. You know, we have this published, we know we should make sure we take views, particularly flexures or areas where we might miss pathology. But actually, I think there's not enough focus on how you actually standardise and improve the quality of your documentation. And just like we have nurses who are doing drug rounds who have these bibs that say do not disturb, I think the time of report writing is particularly busy time in the endoscopy unit where you need to make a concerted effort to minimise those distractions. You've got the sign out happening, you might be checking histology, the nurses are keen to turn the patient over, the patient might be asking you additional questions, and at this point you might be quite fatigued. So this is a time where errors will occur. But the report is important because it's a surrogate marker of the quality of the procedure. And we've talked about the importance of photo documentation, particularly with post-colonoscopy colorectal cancer and also upper GI cancer post-OGD. And it has to be an accurate reflection of the case. You can't say the patient had minimal discomfort if they really didn't. That's not helpful to anyone. And I think targeting the report to the audience, so it has to meet the referrer and the GP's question, but also to the patient as well. Being accountable to your management plan is really important. Vague statements don't help. Who's going to check the histology and who's going to book the surveillance? We heard in the previous talk this morning that lots of problems with IBD surveillance, patients being missed. These patients go on to develop cancer, which is totally avoidable. And really, I like to think of my endoscopy report as a standalone document, such that if my patient were to present with a complication at another hospital, that report is not just a technical summary of the endoscopy, but a clinical narrative of what I did, why I did it, and what the outcome was. So to summarise, ladies and gentlemen, I've presented 6 mistakes in endoscopy that I think occur quite frequently. Patient selection, doing a procedure on the patient that doesn't need it. Planning and preparing, think about employing briefing toolkits in your checklist really effectively. Think about making your intubation as comfortable as possible for the patient, because then you buy their respect and trust and actually spend more time doing your job, which is detecting pathology on your extubation. Be considered about your extubation, take your time, make sure you use all your adjuncts, and have a low tolerance for poor prep, for example. And then how are you going to manage complications? So thinking about employing your communication and non-technical skills when you do come across those very difficult scenarios. And finally, documentation, thinking about that as a clinical episode rather than a technical report. So my take-home messages: mistakes will happen, they're very common, they happen up and down the country. The key is, I think, we can minimise the impact clinically of these mistakes by doing the small things reliably well with some of the safety tools that we have if we employ them more thoroughly. And if we start with the groundwork of safety, then we can aspire to endoscopy quality. And I think with JAG and BSG, we can aspire to endoscopy excellence. Before I close, I'd like to invite you to our Frontiers meeting at St Mark's in the autumn. You'll be all very welcome. It's about tackling uncertainty in colorectal disease. And I'd really like to thank all of my colleagues, particularly the team at St Mark's and Vats Ravindran, who's provided me with some of the slides, Adam Haycock, and particularly Shuan Thomas Gibson, who's been my supervisor and mentor, and without whose tuition I wouldn't be asked to be doing this talk today. So thank you very much.
Thank you very much, Doctor. I've got some questions from the audience for you. So we have a question from Aaron. His question is: patient selection for endoscopic procedures isn't only in the hands of the gastroenterologist. How can we better educate our non-gastroenterology colleagues on the importance of providing comprehensive patient information, and what strategies can we use to improve the vetting of the process to ensure that patient fitness is put before coming in for the scope?
So yeah, really important question, quite difficult to provide an answer with, but I think it starts with educating our colleagues in primary care and making sure that we have a good working relationship so that if they're not sure about an endoscopic examination, there's open lines for discussion. Referring people back to the guidance on when it's appropriate for people to go straight to endoscopy and when it's not, and giving advice about what they might do in that scenario. I think also within secondary care, we often get referrals from other specialties who may not sort of really understand particularly what a PEG involves, for example. So actually using that opportunity to go and speak to those colleagues and think about actually cancelling the procedure for whichever reason. So I think it is difficult, however, because we don't always have people that we can see, and we're getting patients through straight to straight test pathway. I think the key is things can change from the referral to the point when the patient comes for endoscopy. So if the clinical situation has changed and they may have had a stroke in the intervening period, for example, you're going to need that to amend that endoscopic, indication. So I think it's about a team approach and education of colleagues.
Thank you.
Well, we'll ask a couple more questions. I'll aggregate a couple together. How much time do you recommend spending brief and debrief per patient? And given that is important, how realistic is it to do 10 points on a list? And we've got to do a court procedure, do the reporting, etc.
Really important question. So we, as part of my research, we actually timed the length that a checklist took to add onto the procedure, and on average it was about 36 seconds. So the checklist itself didn't add more to the procedure. Where it did add to the procedure is where things hadn't been addressed beforehand. So the briefing needs to be just done once at the beginning of your list, and I guess it's before your list starts, and you can spend as long or as little as you like doing it, but you don't need very long, I think is the key message. You can do a good team briefing within 5 to 10 minutes if you have the relevant clinical information. If you don't have the clinical information, then it takes longer, but then I would argue that you need to take that time because it's going to prevent errors down the line. But I think this is a constant thing between being efficient and having high quality, and we shouldn't see the two as mutually exclusive. Doing the briefing might take a bit more time and add on to a list, but it's certainly going to save you time when you avoid a patient that didn't need an endoscopy. That's going to take a lot longer doing a serious incident investigation.
Thank you. And if you have had a complication during your list, should that endoscopist do the next case?
So I think there's no set rule about this, but I think an acknowledgement that that endoscopist may not want to do that next case or may not be the best person to do that next case, and normalising that is completely important. I think we have a bit of macho culture still in endoscopy and in surgery. We're doing increasingly therapeutic semi-surgical procedures, but actually recognising that you might not be right to do the next case is totally normal and totally fine. It's important for the patient, but it's also important for the endoscopist. I think how you manage that afterwards is really important, separate to the debrief, which is about the immediate situation. There's a publication from the Royal College of Surgeons where there's almost like a toolkit for managing serious complication, which is, preparing for some of the incident reviews, thinking about maybe even going to the coroners and actually providing really important psychological support, because we know this has a real impact on endoscopists as well as patients, of course.
Any comments on right colon retroflexion?
Yeah, so I think it is a good way of making sure that you optimise your views. I think you have to think about doing it safely wherever you do retroflexion, and thinking about why you retroflexion. Is it because you haven't got optimal views? Do you have an endocuff on? Do you need to retroflex? Position change might help. But I think it's definitely a good way of improving your visualisation. So, however, you don't need to always do retroflexion, because if, for example, there's a scarred colon, or it may not be easy to do because you've got an endocuff, then you could cause patient injury, perforation. So I think about why you're doing it and think about how it's going to help you. If it's going to, then go ahead. If it's not, then don't do it.
Thank you very much.
May nakatayo dito kanina. May nakatayo dito kanina mag-ask. Kaya tanong
Thank you very much. I'd like now to invite our next speaker, Dr. Ramis Wise, who many of